I know that there's been a lot of concern that out-of-hospital services are as robust as possible as the process of reconfiguration progresses. So I do want to reassure the committee that CCG is committed to investing in community services, and this year we will be making extensive local investments totaling about £5.5 million, focusing on primary care, unscheduled care, planned care and IT, to give some sort of overarching headings. So with regard to primary care, we're currently in the process of extending the amount of services or the type of services available in general practice. We are aware that some GPs or some smaller surgeries may be more challenged than others in providing certain services, just because of limitations on staffing levels. And so what we're going to do is to use GP networks to provide certain services on a networked basis, to try and make sure that we've got equality of access to services right across the borough. We're very aware that some of our smaller practices are clustered in the north of the borough, where we have higher levels of deprivation and higher levels of health need, and that it's quite often easier for bigger practices to provide the manpower to provide extra services. So we're providing them on a network basis. With regard to unscheduled care, we're investing a lot in integrated intermediate care services, and I'm sure a number of the members may well already be familiar with the Community Independent Service, which is a joint project between the CCG and the local authority. And over the last 12 months, we've extended that service to now Community Independent Service Plus, which some of you may have heard previously called virtual ward. We haven't really been able to find a snappy title for it as yet. But basically what this service allows for is much more rapid access to higher levels of support in a patient's home, with the hope being that we can support them safely at home rather than admit them to hospital. So what the patients are able to access is access to home care within 2 hours. They'll be initially reviewed by a GP, probably who will refer into the service. They then can have access to district nursing service the same day, to re-ablement services, OT, physiotherapy. And that service will go on for a period of up to 6 weeks, with the patient gradually, the individual gradually stepping down in intensity over that period of time. The number of referrals to the service is growing gradually. With anything like this, it takes a while to bed in, but it's growing gradually, and we're now up to about 80 referrals per month. We've also recently had a consultant care of the elderly physician team. We're in the midst of accessing more GP support specifically allocated to the team as well. And what Tim referred to earlier on is we had just agreed in our board meeting earlier in the day further investment in this service that would be linked to increasing levels of patient activity. What we're seeing is a steady rise in the number of patients referred from general practice, but also patients referred from the hospitals, from the A&E department. They're providing early supported discharge for patients. We're monitoring the activity quite closely, and so we are looking at things like, okay, how many patients are actually ending up in hospital despite best efforts? How many patients who've had an early supported discharge are ending up going back in? And the data, the service in its current configuration is relatively new, so the data is, we've only got about 2 months worth of data so far, but we are monitoring this very closely to see if it's going to produce the benefits that we think it will do. We're also monitoring patient satisfaction with the service, but as I say, we've only recently implemented it in its current form, so we haven't got that kind of data to give to you today. Planned care, again we're investing money in planned care. What we're trying to do is to move some aspects of planned care closer to patients. So we've got specific focus on diabetes services and on respiratory services. We've got other pathways in line as well, including heart failure, ophthalmology and gynecology as well. And we're also increasing the cover for the urgent care centre at the Hammersmith hospital site in line with the EU closure. So the Hammersmith Hospital Urgent Care Centre is now operating 24 hours a day, 7 days a week, has been since early June, and that will continue on through the rest and ad infinitum. So, another area which we feel has been is important is actually investment in IT, in infrastructure and connections. One of the things as a GP that is constantly frustrating, and I think patients find it frustrating as well, is poor communication between GP and other care providers, whether it's community care providers or hospital trusts. So we currently have all the GPs in Hammersmith and Fulham on a single IT system. That IT system has the capacity to link in with other systems. So the urgent care centres will soon be using the same system. So with patient consent, what that means is if I or some other GP sees the patient in an urgent care centre, if the patient consents, I can look at their records in the GP surgery. And then when I see the GP or when the patient sees the GP the following week, they can have an immediate look at whatever information has been gathered at the urgent care centre. We've also had very constructive conversations with Imperial Healthcare. They are planning to use System 1 in their elderly care service, and the overall plan is to create a gateway that will allow two-way access between their system and our system. Because again, the flow of information, I think it links into what Brian was saying earlier. I often have patients coming into surgery confused about what's supposed to happen next in their hospital journey. And if we were able to get those systems linked up, which is a big priority for us, I think it would improve patient care greatly.
Jack, can I just ask a quick point of clarification?
Yeah.
That ubiquitous system with patient consent, is that just for patients of Hammersmith and Fulham CCG, or is it also Kensington and Chelsea?
Yeah, it's not just for us. Most of the 8 North West London CCGs have made a decision about adopting a single IT system for their GP practices. The one that Hammersmith and Fulham has chosen has already been implemented in Hounslow. I think there is agreement including.
So the purpose of my question is that a lot of my constituents in my ward are registered with GPs in Kensington and Chelsea because of the geography of the ward. It's the same system. Thank you.
So we move on to the next slide. Improving access to primary care. So we currently have 7-day access to primary care, which started up during the winter time as part of the winter pressures schemes. So Cassidy Road, which is a GP surgery in the Fulham area, is open between 9 and 4 p.m. Saturday and Sunday. There's walk-in or appointments available for patients on an urgent care basis, so you don't have to be registered with the practice. We're in the process of trying to procure a similar service at other sites across the borough. So we've requested bids from local GP practices and had a good response to that. We're in the process of examining those bids. And that would be seen as a bridging measure. Ultimately, our overall aim is to provide weekend services at several sites across the borough, and that's in some way supported by the PM Challenge Fund, and that is an overall North West London strategy. If we move on, so you all know hopefully that the Parkview Centre for Health and Wellbeing has recently opened. The GP practices have moved in there, and there's a lot of other services. I think it would be true to say that there is still some way to go to turn this into an entity that operates in a truly integrated fashion. We were all aware that that was going to be a challenge, and I think it still is. It's very difficult to get people to change the way that they work, but this is a big step forward from that point of view to providing better health care in one of the most deprived areas of the borough.
How many people, so it's not saying, how many patients?
So at the moment it has 4 practices in it. I know that at least one of those practices has the capacity to register at least another 5,000 patients. So there is definitely room for expansion in it. I would say, knowing what I do about the current occupancy level in terms of GP practice, I would say you could probably register at least another 10,000 patients in there.
We have some figures just to be clear on that.
We should be able to supply you with some. There's been a whole work stream attached to this that the borough has been quite involved in, and because obviously we've had a partner from social care involved in the whole thing, so we should be able to supply that information for you. We're going to move on. So I've already spent quite a lot of time waxing lyrical about duty impairments. I won't be doing more about that, so I'll just do the next one. So shifting settings of care has been quite a big project. We're very aware, as in many boroughs in London, in Hammersmith and Fulham, mental health issues are a large burden for a sort of proportion of our community. And it's one of the biggest issues that affects quality of life for patients. So the shifting settings of care programme has a two-pronged approach really. One is about active in-reach into community mental health teams to bring patients with sort of mild issues or stable, moderate issues back into primary care, whilst providing upskilling for GPs, and then also providing extra support in the form of a community psychiatric nurse who can monitor those patients discharged from the community mental health team, but also provide early advice for patients that GPs are newly diagnosing with mental health issues. So we're monitoring it quite closely. As you can see, the numbers are still reasonably small. We've had 65 patients successfully discharged so far. 20 out of the 31 practices in the borough have signed up. Again, some of the issues we've had around practice sign-up is with regard to some of the smaller practices because they have concerns about the manpower that they would need for this. It is funded, the time for it is funded, but they still are concerned. So we're looking at ways of how to best deal with that to make sure all patients have access to the same thing. But so far what we've seen is that those patients who've been discharged have not needed to be referred back to community mental health team. And we've had a number of patients who have been diagnosed and partially managed by the community psychiatric nurse in collaboration with the GP. So I think we're seeing a significant upskilling of the skills in general practice with regard to dealing with a certain cohort of patients. Increasing dementia diagnosis. I think we're all very aware, it's got a big national highlight as well, that dementia is a significant problem and is going to be increasingly problematic as our population ages. We're also aware that within Hammersmith and Fulham, very similar to lots of other London boroughs, that we are underdiagnosing dementia, that there's a significant proportion of patients out there who we still are unaware of. So we have been looking at various ways of trying to improve our diagnosis rates, and we've been succeeding well. As it's a big national focus. We have a target for last year, which was increasing our rate up to 45%, which is 45% of the estimated prevalence of dementia in H&F, and we actually achieved 52%. Our target for this year is 67. So one of the things, we've been doing a number of things. One of them is actually putting training into general practice. So we have had one of the consultants who runs the local dementia service going into GP practices to run educational sessions for the GPs about benefits of diagnosis, when to make a referral to the team, how to manage certain issues with the progression of dementia. Because I think to some degree, with some GPs, you still have a bit of a hard sell in terms of convincing them that diagnosis earlier on in the pathway is important, which it undoubtedly is. Dementia, unfortunately, is still a condition that we cannot cure, but all the evidence suggests that if you're aware of the disease earlier on in the process of it, that you're more likely to be able to support the individual in their own home for as long as is humanly possible. So one of the other things we've done as well is taken the decision of employing a dementia nurse. What we've noticed is that because the hospital trusts have had focus for the last couple of years on screening inpatients for dementia, what happens then is that there will be a discharge summary sent to the GP saying, was this patient screened for dementia? Yes. Was the screen positive? Yes. And then some response will be expected from the GP, and there is evidence that some of those patients fall through the cracks. When an older person is acutely unwell in hospital, it's not uncommon for their cognitive function to sometimes to be slightly impaired. So what you really need to do with those patients is reevaluate them a number of weeks after they've been able to go home, to then make a decision of whether they need onward referrals. So what we have decided within H&F is actually that we're using a dementia nurse to help fill some of those gaps. So we're actually trying to make sure that those patients aren't slipping through the net and are being followed up in the way they should be. And lastly, just if we move on, to improving access to psychological therapy. So again, with regard